parental pressure and the drive to succeed, females in athletics, family eating patterns, relationships, and environmental factors such as society's pressure to have the perfect body can all contribute to the development of these disorders. As you know, anorexia is the voluntary refusal to eat, with alterations in body weight from consuming fewer calories than required to meet metabolic needs. Clients with anorexia are typically overachievers, perfectionists, and have obsessive thoughts. They often exercise to excess, and their nutritional intake is limited to low-calorie foods with consumption of as little as 500 calories per day. Anorexics may engage in starvation to control other factors in their life. Fine body hair or lanugo, hypotension, and hypothermia are present with anorexia. Hair and nails may be dry and brittle. Appearance is gaunt. In contrast, bulimia is episodic, uncontrollable, and compulsive. Binging, the rapid ingestion of large quantities of food over a short period of time, is followed by behaviors such as self-induced vomiting and misuse of laxatives, diuretics, and enemas to rid the body of excess calories. Bulimics usually maintain a normal body weight range. Clients with bulimia engage in secretive fasting and binging after eating high-calorie foods. Caloric intake may be as much as 20,000 calories per day. Vomiting typically follows food intake. Calluses on the fingers result from self-induced vomiting, tooth enamel is worn away by vomiting, and dental caries and erosion follow. Compulsive overeating leads to obesity when there's no attempt to prevent weight gain. Some obese clients binge while others do not. Signs and symptoms of eating disorders include the presence of mental health disorders such as depression and anxiety, self-mutilation, suicidal ideation, and substance use. The client may experience a distortion in body image and weight loss, gain, or fluctuation. The client may have an obsession with food that is evidenced by talking about recipes and food preparation. Abuse of laxatives, diet pills, diuretics, and steroids is common. And symptoms of medical problems related to an eating disorder include electrolyte imbalance. The nursing assessment includes a history and physical, with baseline weight and height measurements. Necessary questions include: do you think about food often throughout the day? Do you have regrets after eating? Do you use laxatives, diuretics, or diet pills to control your weight? Do you vomit after eating certain foods? Do you eat uncontrollably? Do you feel hungry most of the time? Do you feel anxious when you're unable to exercise? Are your menstrual periods regular? The assessment includes a mental status exam to identify inappropriate coping and abnormal eating patterns, nutritional assessment to assess eating habits and caloric intake, social history about family interaction and relationships, family history to assess influences and cultural patterns of eating, and routine height and weight comparisons. What do you think are the most common nursing diagnoses? Anxiety, alteration in nutrition, body image disturbance, alteration in thought process, impaired social interaction, risk of harm to self, powerlessness, self-esteem deficit, ineffective individual coping. Once again, our nursing interventions include safety. Safety for the client means protection, particularly around meal times, to keep the client from vomiting and/or using excessive exercise to diminish weight. Meal planning includes the diet, the amount of time the client will have to eat, how the staff will respond to the client during meals, follow-up after meals, and how staff will respond if the client does not complete meal requirements. The nurse can educate the client while planning for meals by explaining the benefits of good nutritional choices, like saying, eating a banana and a piece of chicken will raise your blood sugar and you'll no longer feel dizzy. We'd agreed that you'd finish eating by 1 p.m. That means you'll no longer feel dizzy when it comes time for your family to visit. A client contract may be used. One-to-one supervision might be necessary if the client does not adhere to the plan or has a high risk for suicide. Another priority intervention is the correction of nutritional and electrolyte imbalances. Since the client is secretive and manipulative in attempting to control weight, you should obtain an accurate health history, including eating patterns. And behavioral contracts can assist the client in maintaining an appropriate weight. A dietitian is consulted to develop the appropriate diet. A client with anorexia may engage in water loading prior to weighing to conceal weight loss. The nurse must prevent this activity. The client should be weighed at the same time each day with the same amount of clothing. Avoid telling the client the current weight. Individual therapy includes improvement of the client's self-esteem, coping mechanisms, problem solving, and stress tolerance. In life-threatening situations, enteral nutrition or tube feeding might be necessary. Okay, now let's apply our understanding of eating disorders to the following client. A 17-year-old female is admitted to the mental health unit. She's 5'6" and weighs 75 pounds. As the nurse begins the admission assessment, the client states that she's overweight. She asks about the number of calories in the meals and about alternative choices. She reports feeling tired. However, she later exercises in her room with the door shut. Her lab work indicates that she's hypokalemic. She has not had her period for 1 year. What is the significance of the client wanting to know how many calories are in each of the items on her tray? Answer: the client can control how much weight she gains if she knows the calories in each food. What additional questions should the nurse ask if the client has an eating disorder, such as anorexia or bulimia? Answer: has a client used laxatives, diuretics, or enemas, or induced vomiting? Clients with bulimia consume large quantities of food and then use ways to rid their body of calories such as laxatives, diuretics, enemas, or self-induced vomiting. Clients who have bulimia are usually within a normal weight range, while clients with anorexia refuse to maintain a minimum normal body weight. What behaviors would the nurse expect the client to exhibit related to food on the unit? Answer: the client will want to control all aspects of her meals and snacks. She may hide food and try to induce vomiting without the staff knowing. Sometimes she may refuse to eat or may be obsessed with discussing food. What are some complications that the client will experience as a result of the eating disorder? Answer: dehydration, electrolyte imbalance, especially hypokalemia, constipation, amenorrhea, loss of tooth enamel from vomiting, hypotension, hypothermia, and cardiac dysrhythmias. If you were the nurse developing this care plan, what are some important nursing interventions you would include? You would plan meals with the dietitian to ensure adequate calories, allow food choices, observe for water loading prior to meals, have consistent staff responses to food consumption during mealtime, and observe the client after meals to guard against self-induced vomiting or exercise to control weight gain. The nurse for this client would also assess the interactions and relationships within the client's family. The nurse identifies that the family interactions are enmeshed, rigid, and overprotective, and lacked conflict resolution. Which additional factors do you think might have predisposed the client to an eating disorder? In this case, how the family deals with conflict. Avoidance is typically used, and power and control issues are also evident. Criticism promotes obsessive and perfectionistic behavior, while the child tries to gain love, approval, and recognition. So eating problems become a way of rebelling when the child develops ambivalence toward the parents.